Hi, this is Dr. Rich Schering. I'm going to talk with you today about point-of-care ultrasound, common approaches used in novel environments. This presentation really comes from my experience both as an Army flight surgeon and using ultrasound in combat zones, something I did very frequently for soldier healthcare, and also using it with astronauts before, during, and after spaceflight, where ultrasound is our only imaging modality. So hopefully you'll enjoy this. Again, ultrasound has been used in many unique ways, primarily because we just thought to do it, and because of its portability, its relatively minimal cost relative to other imaging modalities, the ability to do dynamic imaging and use comparative views with the unaffected limb or something similar. It's been a perfect modality for getting images in austere environments. Real quick, this is just a general overview of common uses of ultrasound in both deployed military and microgravity environments. It's not medical advice or a complete course of training. For those of you who practice as a sonographer or sonologist, you know that this takes years of practice and expert consultation to really get your exam down. So this is just to give you kind of a point of reference and give you an idea of how we use ultrasound in novel environments. So to start, just showing you images of both the military deployed and space environments. On the left upper you see me doing a knee ultrasound with an old Sonosite Titan machine that I used in Iraq. Did hundreds of exams on soldiers with this device, both for diagnosis and treatment. And in the picture below, Camp Bonston, Kosovo, did pretty much similar practice here with the Sonosite M Turbo. Fantastic portable device, very reliable. We did lots of injections in the extremities. It wasn't uncommon to use this for plantar fascial injections or ankle injections, posterior tib, or to drain meniscal cysts in the knee with meniscal tears. I mean, all kinds of applications. I actually used ultrasound in pilots with chronic SI joint pain, using ultrasound for an SI joint injection, something I'd never done without fluoroscopy, but ultrasound was all I had, and the technique worked very, very well. So in space, back in 2005, Gennady Padalka, a Russian cosmonaut, and Mike Fink used ultrasound for the first time to actually do real-time imaging of shoulder, and was able to send these images down to the ground basically as a proof of concept that we could actually use ultrasound with remote guidance to get quality images that could be used both for diagnostic and then with the potential of actually doing therapeutic injection. That's not been done yet, but certainly the potential is there in low Earth orbit. And that paper was funded through the NASA Science Organization, the Human Research Program, and the paper was published back in 2005 in RSNA Radiology. Space is actually a really unique environment because you're going 17,500 miles an hour around the Earth in low Earth orbit, which is about 220 nautical miles above the surface. You're circling the Earth every 90 minutes. Your communication with the ground can be sometimes limited, so having something that you can train up a crew to use with relative minimal training and be able to get diagnostic quality images was really a really strong requirement for us, and ultrasound met that demand. Medical care in space, a lot of folks might think it's really different. In some ways it is. If you had to do CPR for whatever reason, Dan Burst demonstrates in the ISS Expedition 4 that actually doing a handstand and pushing off the relative ceiling with your feet to allow your decompressions, allows you to do decompressions quite a bit. So it's kind of a novel way of doing something. Or crew will not infrequently get foreign bodies in the eyes, and sometimes just floating a bubble of saline where the surface tension keeps the water in kind of an isolated bubble, and then just kind of floating your eyeball in there and using that for irrigation actually works pretty nicely. You can't drop a drop in an eye because there's no gravity to force that drop to go down, because there is no up, down, right, or left. That's another unique environment that microgravity provides. And you'd alter your treatment somewhat. Also shows you just the physiology, how that might change. Eileen Collins was the commander of Space Shuttle 114, the return to flight mission back in 2005. And here's a picture of her on orbit where her face is kind of very puffy and swollen because of the 2-liter subphallic fluid shift. But for the most part, we practice medicine in space pretty similar to how we practice on Earth, and our ability to get imaging is key. One of the tenets of space medicine is prevention. If you can identify, screen out, prevent disease from occurring, the likelihood of having to treat something very serious in space is minimal, and we've been pretty good practicing along those lines. We can support life-threatening emergencies to some degree on orbit, but the ability to do surgery, do invasive techniques, etc. is pretty limited. And your crew is often not a medical doctor. They may be a test pilot or an engineer who get minimal training. This picture of a surgical suite with surgeons doing a laparoscopic or arthroscopic technique is shown, and that's not something you have in space. The picture on the right is what we call our checks rack, which is our crew healthcare system for the ISS, and everything that you have medically, your diagnostic equipment, your medications, etc., is in that rack, and you can appreciate that there's probably not a lot of room for stuff there. But if you're screening disease out and you have really healthy people, you generally don't need a lot of medical capability. We do provide for life, for ACLS capability, but again, that's somewhat limited. It's not something we've actually had to use. So that crew medical officer, that astronaut who maybe gets 30 to 40 hours of medical training, is really dependent on their air-to-ground communication with their flight student on the ground. This is a picture of me in mission control at NASA in Houston. If an astronaut has a problem, they're going to call down, talk to me on a private space-to-ground loop, and I'm going to help them work the problem. But I'm also going to be relying on my experts in any type of medicine, neurology, cardiology, orthopedics, etc., to help me work that problem real time. But one of the keys to making the diagnosis is being able to get imaging in many instances. So we may have the crews take pictures of the rash or something along those lines, or in the case of, let's say, a shoulder or elbow or knee problem, getting ultrasound is going to be the only way we're going to get insight into what's going on in that joint. This slide shows you the relative types and frequencies of medical conditions in event person years from both Space Shuttle on the left and then the Mir missions during the 90s on the right. And for the most part, it's a safe, pretty healthy environment, but you do get sprains, strains, skin rashes, sleep disturbances related again to just a disruption in the circadian rhythm. But for the most part, the crews actually do pretty well. But you can certainly see with sprains, strains, and contusions, having an imaging modality like ultrasound would be very useful. Again, getting back to, this is kind of our work environment. We're communicating from the ground up to the space station while this thing spin around the Earth at 17,500 miles an hour. How do we get the best insight as to what is the exact diagnosis of this shoulder pain, or this, hip discomfort, or, this ankle swelling? We really have no other way besides just guiding the crew member through the physical exam, asking questions in their history or mechanism of injury, and then being able to use an imaging modality like ultrasound. So it's a challenging environment for sure. Published a paper back in 2009 outlining the musculoskeletal injuries and minor trauma that happened in the U.S. space program from Alan Shepard's first flight in the early 1960s all the way through about December of 2006. And although again, musculoskeletal injuries were relatively benign or mild, they were not uncommon, and having the capability to actually adequately diagnose and treat these is a real important part of what we do as far as space medicine. This chart just shows you the types and regions of injury and the numbers of injuries that we have. The majority are in the hands, related to the fact that in space your legs become your hands. Everything you do is translating through the station or doing stuff with your hands, so you're more likely to get paper cuts or bumps or bruises or contusions. Rarely you might have something like a finger dislocation, which had happened on a mission where a crew member got his finger stuck under one of the D-rings and provided enough torque and load with translation to dislocate the PIP joint. But again, pretty uncommon for something like that. On the lunar surface, this was a lot more interesting because you did have gravity, although albeit at 1/6 G. But crews did describe falls and other instances where they actually did develop muscular injury. This video that I'm going to show is Harrison Schmitt on Apollo 17 in 1972, where he fell, and you'll get an idea of the type of mechanism or concerns we would have with falling in a planetary environment. So you look at the mechanism of fall, an outstretched hand, bracing for fall. You could have anything from just a simple, wrist strain to a frank, distal radial fracture, certainly knee, hip, lower extremity injuries are all things that you would really like to have insight into as far as if they came into their spacecraft or their habitat complaining about pain. You're going to want to try to understand exactly what that is, and ultrasound would really help us out quite a bit. When we spent time talking with the Apollo astronauts, we found there was really 9 events that they described where the mechanism of injury was pretty clear. The majority were in the hands, but we did have one injury that occurred in a crew member in his shoulder, where he most likely sustained a slap injury during his 3-day mission. And he actually took quite a bit of aspirin to try to relieve his pain. Again, having ultrasound there to actually be able to do a remotely guided, regional exam of the shoulder and get a good look at the rotator cuff, the bicep tendon, the posterior shoulder to look for glenohumeral fusions. All these things we could do with ultrasound and would really give us a lot of insight as to, what was going on with this crew's shoulder. Would they be able to go back out and do another EVA if they had to? What were the implications for treating this crew? Would we just treat them with anti-inflammatories versus trying to do an ultrasound guided injection? All these things I think ultrasound would be able to help us answer, in addition to trying to do a limited physical exam. So that's really the challenge. You've got this remote vehicle, you have people doing the exam who would not be physicians. They would be reliant on their flights from the ground, and all these things would really provide quite a bit of challenge. But having that added modality where we could actually get an image of the soft tissue, of the connective tissue, of the joint, would actually help us quite a bit. We do not have X-ray, we do not have CT scan, we do not have an MRI, and if you consider, in terms of mass, power, volume, money, those modalities are very heavy. They require quite a bit of training, etc., etc. Portable ultrasound, you've got the device right there. The training is really minimal, relatively speaking, and you can get very, very good images. You can do dynamic imaging as well as comparative views in the extremities. So again, it's a perfect device for us in remote environments. And this just emphasizes the point when you look at the ISS medical capabilities compared to something that you're all familiar with, like a hospital. It's really a pretty limited capability that we have up there in terms of your diagnostic, therapeutics, communication, etc., etc. Really, it's similar to Everest Base Camp. So it's very, very limited, very austere. And that's in particular true with your communication and the ability to evacuate, but also personnel. The person who might be doing the ultrasound or trying to do the technique most likely is not going to be a doctor. They may have had medical training and they're going to get guidance from the ground, but this is not going to be someone who went to medical school. There's someone who has great eye-hand coordination it can learn very quickly, but doing a blind injection versus doing an ultrasound guided injection has huge implications in terms of accuracy, efficacy, minimizing potential further injury or missing the target. At NASA, we've had to think kind of outside the box because of some physiological changes that have occurred in parts of the body that you wouldn't normally think very much about. One is the eye, because of multiple reasons, probably related to fluid shift, carbon dioxide, salt intake. Who really knows? We've had papilledema and some visual changes. And the use of ultrasound in a very novel way, where you actually get great images of the retina, the disc, the cup, and then the sheath itself, is really revolutionized how we look at the posterior orbit. Here on the left side, one of our Japanese astronauts, Akiko Hoshide, uses ultrasound to scan his retina during a study back on Expedition 33. And then right, you've got Mike Fossum doing an echo cardiogram on Satoshi Furukawa as part of the integrated cardiovascular studies on Expedition 28. Dan Burbanks in this picture here on Expedition 30, getting ready to do an echo using ultrasound again. So again, a lot of different uses that we've used for just kind of normal scanning techniques, but we've had a number of musculoskeletal injuries, and I list these: recurrent knee pain related to probably pre-existing osteoarthritis aggravated by exercise on the space station. We've had hamstring strains, again, that finger dislocation I mentioned. The crew's exercise on the cycloergometer, the CEVIS, and we've had foot trauma related to that, peroneus brevis tendinopathy related to just the shoe rubbing against the foot, and then being able to scan and look at that injury. The EMU refers to the spacesuit, the extravehicular mobility unit, and crews have come out of that. They've gotten pulled out too quickly and developed shoulder pain from a traction moment. We've had low back injuries and cervical spine pain, all areas that we've actually pioneered using ultrasound to actually look at the spine and other parts of the body that you'd never think of before, because again, ultrasound is the only way we can actually do this. Commander Leroy Chow, back in Expedition 10 in the ISS, again, was developing the protocols through ground guidance on how to do orbital ultrasound. Years later, Luca Parmitano from the European Space Agency and Mike Hopkins were using the refined technique and ultrasound probes to be able to actually get pristine images of the optic nerve, the sheath, the retina, and have gotten some really good images using those techniques. That's in flight. Before they get to space, though, they're doing a lot of training in T-38 jets or other mock-ups or simulations. One of the simulations that they spend quite a bit of time in is in the big pool at NASA called the Neutral Buoyancy Lab. This picture is actually me in the spacesuit, learning the environment, learning the mechanisms for injury. And the injuries we've seen related to the suit are listed here in the shoulder. You have rotator cuff tendinosis, rotator cuff tears. We've had subacromial deltoid bursitis, long head bicep tendon tenosynovitis. We've had slap tears, impingement, aggravations of underlying glenohumeral and acromioclavicular arthritis. One of the more common injuries we've had too is lateral epicondylitis, and in the forearm, deeper veins, extensor pollicis longus, aggravation of some mild underlying carpal tunnel syndrome. We'll get delamination of the nail beds and fingers, and we can get cervical and lumbar strains from use in the foot restraint. So all kinds of things can occur, and again, having ultrasound at the pool side has actually helped us with some of the diagnoses before and afterwards. This picture at the top is a crew member I had who got out of the pool after a 6-hour run and had dorsal wrist pain, had crepitance, and I was able to demonstrate both on the unaffected side on the right and then the left side that he had actually developed a really nice acute extensor pollicis longus tenosynovitis. An ultrasound right there at the poolside really showed that anatomy very nice, where you have Lister's tubercle, and then just ulnar to that you have the tendon. And you can see the increase in the hypocholic fluid around the tendon, and then it was a sonographically positive exam as well. And the bottom two images, again, you have a normal right counter extensor tendon at its enthesis on the lateral aspect of the humerus, and then a nice tendinosis, which was not an uncommon injury, on the left side as well. So again, having this right at the poolside, you can get your diagnosis. You don't have to go off and do X-ray, MRI. Really helps guide what we're going to do with the astronauts. They know what's going on. We can relay this information to the flight surgeons. And this is certainly something conceivably we could use in space if we needed to. Another rather unique problem we've had related to space flight return in the Soyuz spacecraft has been anterior thigh pain and numbness tingling related to compression of the lateral femorocutaneous nerve under the very thick straps they'll have to keep them in their seat. And that generally occurred in individuals whose anatomy really had that lateral femorocutaneous nerve closer to the ASIS on the inguinal ligament, as opposed to the normal approximately 2 centimeter medial position of that nerve. So when crew members came back with this kind of anterior lateral thigh paresthesias and pain, we could actually use ultrasound to go and look and diagnose that, and you can see that very nicely. This ultrasound image of the LFCN just off the medial aspect of the SIS shows the nice honeycomb structure of this very small nerve under the inguinal ligament. What's the mechanism of injury? Well, the crew members, when they strap in for launch or landing in the Soyuz, they're seated with their knees towards their chest, and they have this very thick gray strap across their hips, compressing the pelvis into the seat. But underneath that is the lateral femorocutaneous nerve, and if it abuts that ASIS on the inguinal ligament, that could be a source of irritation. And they're in this position for up to 3 hours. One particular crew member came back again complaining about paresthesias in this distribution that you see in this illustration here. And when we scan the LFCN, you actually see this hypoechoic, kind of swollen nerve under the inguinal ligament, with loss of the nice honeycomb structure and short axis view. And that was certainly consistent and with a neuropathy of the lateral femorocutaneous nerve, also known as Meralgia Paresthetica. We've also had crew go up with significant osteoarthritis in the weight-bearing joints, and something that typically gets much better in space because the joints are offloaded, but I've had to use ultrasound to do therapeutic injections to the joint with great results. But again, this is something that conceivably we're going to have to do in space someday. We haven't had to yet, but certainly getting to a planetary surface or something else, the provider and the crew would have the confidence that being able to actually get the target and put the the medication where it actually needed to be to improve their condition could be done very successfully with ultrasound. So that's kind of our quick overview, just to give you an appreciation of how ultrasound can be used in novel environments in very novel ways. Yeah, and really, it's certainly within the scope of the things that we do, both in the military and at NASA, and hopefully something that you might be able to apply in your practice. So thanks for taking the time to watch this webinar, and hopefully you've enjoyed this. Thank you very much.